Good morning, good afternoon, good evening, everyone who's joining us this afternoon for this webinar coming to you from the Hull Deformity Planning course in the UK. Weren't able to run this year, but hopefully we'll be running it in June next year, all going well. It's a great pleasure to have you all with us today, and particularly our two speakers, Professor Heyman Sharma from Hull and Nick Giotakis from Liverpool. We have a great discussion this afternoon, and I hope that you'll all be joining in, particularly also asking questions on your question and answer button. Please use it if you can during today, and we'll try and answer as many questions as we can. So external fixation has been a great tool and Elizarov method, a great method for deformity correction and for post-traumatic limb reconstruction that many of us have been using for many years. And techniques have evolved. Surgery has evolved over time, and what we can do with patients has also evolved. We're always looking for ways to do things as accurately as possible, in a safe way, but also comfortable and good for patients, particularly perhaps good for rehabilitation and perhaps shortening the whole process that the patients have to go through, and also trying to turn them socially, functionally, and also work-wise as soon as possible back to normal life. And in keeping with that sort of concept, this afternoon, our two speakers will be exploring the topic of fixator-assisted deformity correction, which is a method we use increasingly, and there are very specific techniques and concepts that are useful when trying to perform this type of surgery. And so I look forward to the talks this afternoon, and we'll be looking initially at the principles of fixator-assisted deformity correction, and then we'll be having a number of cases that are being presented to you. During these cases, post questions and we'll try and answer them. If you have any ideas, questions and things like that, we'd be happy to try and explore and discuss with you. So it gives me great pleasure to introduce Nick Giotakis, who's going to talk to us now on the principles of this concept. Thank you, Nick. Go ahead.
Thank you, Gavin. And thanks again for the invitation. The topic is very exciting. External fixator assisted deformity correction brings, I think, limb reconstruction at its best in some ways as a specialty where we constantly try to find avenues, innovations to improve outcomes, and not only outcomes, but patient experience. So I think this is really the core target of this method. Now, these are some disclaimers I will start with, which are some are personal, some are institutional. Now, the aim of this talk, from my perspective, is to concentrate on talking to you about indications. So when this is the biggest question, I think, for most of us, on when is it appropriate to consider an acute correction and use an external fixator to achieve this intraoperatively, followed obviously at the same sitting with definitive stabilization with an internal implant. But ultimately, the question lies, when is it safe really to perform an acute correction? External fixator, the vast majority of acute corrections can be performed with an external fixator assisted, and a part of maybe a few exceptions, such as an intra-articular deformity, where you cannot really use an external fixator to help you. But the vast majority of cases that you perform an acute correction, I think there is a role to do this ex-fix assisted for the sake of precision and control. We will cover the type of implant, that would be we can use. We could also look at what are the key elements that will will improve our possibility to succeed. So how to decrease complications, how to have a predictable result, really. Now, there are a number of elements, the most obvious of which is the deformity itself. So we'll go through a number of factors that will affect the indication to perform an acute correction and use an external fixator. So we start with the deformity itself. And what are the elements that matter here? One can be the site. So are we looking at a femoral deformity or a tibial deformity? There can be different considerations between the two. Location is the other obvious factor, diaphyseal versus metaphyseal deformities. The magnitude, of course, so is it a small, is it a large correction? And certainly the direction. So are we moving from varus to valgus or the reverse, internal to external rotation or the reverse? So we will have to make different considerations based on direction, magnitude of deformity. Another very, very important factor, and these five, I think, are in this slide summarizes the most important elements in terms of the deformity, is the location of the osteotomy. Is my osteotomy taking place at the level of the cora, or am I using rule 2, whereby I'm placing my osteotomy at a different level? That can play a role on whether this can be done acutely and whether it can be or gradually. Another obvious area to look at patient factors. So if my patient has had previous surgery or there is extensive scarring, this will be a significant factor to be considered on whether an acute correction is appropriate. We will have to also look at the type of host. We have to look at the healing capacity, which is generally what we do when we have someone who we're planning to correct. And there can be some specific considerations with acute corrections here. Also, at times we have to face situations where we have patients that may not be suitable for external fixation, and we can look at whether we can extend the indication safely and perform an acute correction in some patients. So, if there's one message to be taken home, a take-home message, it is all in this slide, it is all in this sentence. So, how to minimize the risk of failure, how to optimize my outcomes, and make this work predictably, it's all in this sentence. So, thorough preoperative analysis and planning is the key here. So, many of you, if not all, the vast majority, I'm sure you have familiarized with the core principle of deformity correction at the very first webinars. So the very first thing we learn is to perform the malalignment test. So always perform your malalignment test. Always measure not only the obvious deformity, but both. So both femur and tibial angles have to be drawn on both planes. And at the end, after you've done this, you perform the malorientation test. So make sure that your joints are not an origin of another problem that could become apparent after the correction. So you don't want to align, to correct alignment and make a hidden malorientation become apparent inadvertently. It's good practice to simulate your correction. So if you also reproduce graphically, whether on software or on paper, your correction, how you expect your end result will be, then that will help you to reproduce this in the theater setting. So very quickly, just to remind, malalignment test, we look at mechanical axis deviation, and then we look at performing the individual angles. You look at the femur is normal, and the tibia has an obvious deformity on the which it presents as a varus and as translation of the lateral view in this case. I move on now to look at individual considerations in femur and tibia. In the femur, most cases actually, in most instances, you can perform an acute correction. And it can be achievable predictably, including rotational deformities. So the femur tends to lend itself more possibly than the tibia for acute corrections. Tibia also, we can very, very predictably, safely perform certain corrections from varus to valgus, for example, recurvatum to procurvatum, whereby the common peroneal nerve does not get stretched. It gets actually into a more relaxed status. So this can be done safely. So if you have any of these deformities, you can perform an acute correction. However, we start looking now at elements that may preclude us, or you may make us take a step back from an acute correction decision. History of infection, not only in the femur, but also in the tibia. In the femur, traditionally, we used to be taught that a large procurvatum deformity is probably something to be considered a contraindication for an acute correction. It used to be a rule of 20 degrees. However, it's debatable. In our unit, for example, we have performed corrections, acute corrections for up to 40 degrees without any problems at all with the sciatic nerve. So the worry here is the sciatic nerve getting lengthened. You could perform a correction of that kind beyond 20 degrees, but what would be advisable is to ensure that there are no elements to suggest that the patient has a tight sciatic nerve, so that there are no irritation, nerve root irritation. So perform a straight leg test to make sure that this is not the case preoperatively. Another traditional difficulty would have been lengthening. So whereby lengthening is performed with external fixators, then you don't have the luxury on correcting a deformity and achieving length. So if you have a deformity and shortening, then traditionally we would not use an acute correction, but we go gradual. But nowadays, with popularized lengthening nails, this is not necessary. Is not anymore a problem in many setups. However, congenital deformities and extensive scarring on the concave side can be. You have to be very careful. So those very selected cases can be only performed acutely. In the tibia, the direction, if the direction of correction such as valgus to varus or procurvatum to recurvatum, which puts the comoperoneal nerve into tension, they should not be done acutely unless you perform a neurolysis of the comoperoneal nerve. So yes, they can be done, but you have to perform first neurolysis. Rotation is more tricky in the tibia. Generally, you're better off using a gradual correction for rotation, unless you have a small internal to external rotation. But again, the tibial nerve can go into tension, so you're better off doing this with a circular frame or in a gradual way, regardless. Congenital deformities, again, in the tibia can be very problematic, and if there's scarring on the concave side, as discussed before. So take-home message, in some of the directions in the tibia in particular, you need to consider, or not consider, but perform the release of the nerve. What implant can I use? Nails are fine to be used when you have a diaphyseal deformity and you're using rule 1. So if your cora and your osteotomy at the same level, you're fine to use a nail in the tibia and the femur. In the femur specifically, if you're using rule 1, so osteotomy and deformity and cora are in the same area, then you can nail, again, safely. Even when you use rule 2 in the femur, provided the correction is not very large and provided the distance between the osteotomy and the cora is not very large, you can still use nails. However, if you have the diaphyseal osteotomy using rule 2, the canal will not line up, so you need to use a plate. If you're using a rule 2 for a large correction, or there's a big distance substantive distance between cora and osteotomy, then you need to use a plate in the femur. In the tibia, we recommend in general metaphyseal deformities are treated with a plate because of the difficulties on maintaining the reduction with intramedullary implants more than in the femur. Another question is, what type of fixator shall I use? You can use a monolateral rail type fixator whereby you have the benefits of excellent accuracy. You can measure grade by grade actually on dedicated clamps the movement. It allows compression, which is very important, that prior to inserting your internal fixation implant, you achieve compression. You have special clamps that allow you to perform translation, rotation, correct angular deformities. It relies that you apply your pins perpendicular to the anatomical axis. This is the key here. What are the disadvantages? It's that the first two pins are particularly demanding. You have to be absolutely precise, spot on. It is not a forgiving technique if you get them wrong. There is therefore a significant learning curve. You can otherwise use a circular frame, and hexapod frames tend to be the standard, the most commonly used for intraoperative corrections. A hexapod can be less demanding than a rail to apply in this situation. You can use a chronic mode application, and you can plan, pre-build your frame, have it ready, apply it, and once you have your struts all at the same length, you should have achieved the correction. Now, one of the disadvantages is that with nailing, that the rings have to be far away, so the control can be a little bit tricky. And if you have a residual deformity, then you will have to descrab, recalculate, and add on some time in the operating theater as a result. I'm going to show some examples of the principles. Tibial diaphyseal deformity. We illustrated before the principle of perpendicular positioning of pins against the axis, as you can see in this case. If you consider intramedullary nailing, in rule 1, diaphyseal deformity, you have to place your pins behind the track of insertion of the nail. So here's the case I showed you earlier on. Here's the deformity, tibia only, position of pins posteriorly, perpendicular to the axis, proximally, and the same distally and the same proximally. So outside of the track, into the track of the nail, your wire is down. The osteotomy was performed after position of the pins, and this is the outcome. Postoperative radiographs and the final result. Quite a simple case, but illustrates very well how you can use an external fixator in a diaphyseal deformity and perform nailing. More commonly, we use these for periarticular deformities. So in the proximal tibia, there is a case. I'm not going to draw all the angles, but I will, for the sake of time, but I'll show you the tibial angles here. You can see the deformity. You can see the cora. In this case, a dome osteotomy was planned, so therefore, you have rule 1. You can see the pins have been placed perpendicular to the proximal segment, anatomical axis of the proximal segment. The pins distally perpendicular to the axis of the distal segment. So when you manipulate your osteotomy and you place your pins parallel, your fixator pins parallel, then you will have achieved correction. This is illustrated here, and as you can notice, the fixator was placed on the opposite side where the plate was intended to be placed, therefore is not on the way. And this is the final result. Distal femur, similar case to the one I showed you earlier. So here are your angles. Oblique plate deformity, some translation as well. You can see the pins projected to be placed perpendicular on the distal femur against the anatomical axis, and the same proximally. I'll go quickly through the steps of application. Professor Sharma will show later on more cases. So you can see again the pins placed posteriorly but perpendicular to the axis, and the same proximally, posteriorly to the intended area of insertion of the nail. So here is we're applying rule 1, so the osteotomy is going to be at the level of the cora. The nail has been passed through, and here's your correction and the final radiographic result. This is the last case I'm going to show, femur and tibia. This is a more complex deformity of femur and tibia. You can see the tibia, there is a resultant total deformity of 6 degrees. In the femur, you have an obvious deformity in the mid-diaphysis, but when you perform the full planning, you can see actually there's a hidden deformity, and the two actually tend to compensate each other here. Thereby, in this case, we chose to correct the tibia acutely and also consider acute correction of the femur and lengthening with an intramedullary implant. In this case, because the two deformities tend to compensate each other, the correction of the femur that was required was minimal, only for a few degrees, approximately 3 degrees in total. But the first step here is to perform the CPN release. So the nerve has to be released first because of the direction of correction. So again, X-fix assisted technique on the tibia. Fixator on the opposite side. You can use you can see the plate being inserted. We measured the axis intraoperatively. Professor Sharma will show some cases as well and the method. So the same now in the femur, we applied external fixator perpendicular to the axis. And the nailing procedure and the result after lengthening. So you can see that both tibia and femur were corrected, and this was all done intraoperatively, X-fix assisted. The lengthening obviously was a very graduated process, and that's the lateral view. So yes, this can be achieved. You can achieve predictably good corrections with whether more lateral circular frames, external fixator assisted acute deformities. What the take-home messages here are that the femur is suited for most deformities to be done acutely. The tibia has more limitations. Additional surgical steps may be required, such as release of the common peroneal nerve. Preoperative planning has to be very detailed to all steps. This is the most important element of the method. You can then choose different devices, but as long as you have performed a very thorough preoperative planning, then you will have the answers of whether there is a scope for this technique to be used in your patient. Monolateral rails can be advantageous, but technically demanding, so you need to familiarize with the method. Again, I will highlight that you have to consider the structures at risk, and particularly the nerve and vascular structures, and particularly even more soft tissue scarring, congenital etiology may make you consider more to shift towards a gradual correction. Very quickly, remind you about the implant. In the diaphysis, if you have a rule 1, you can use a nail. Rule 2, you need a plate. In the metaphysis in the femur, rule 1 and small correction rule 2, you can use a nail. Otherwise, it will be a plate. And the metaphysis in the tibia, you better off using a plate. Application considerations, your pins to be out of the way of the internal fixation implants. You need to strive and aim for a minimally invasive osteotomy. Familiarity with minimally invasive techniques is very important, and you have to perform additional planning considerations such as reverse planning when you are planning to lengthen with an intramedullary device. So again, planning is the key. That is really the take-home message of this talk, and not only of this talk, really in deformity correction. Thank you very much for your attention.
That was excellent, Nick. Great talk, very clear, and lots of information there. So I hope everybody who is participating this afternoon was paying attention. Not many questions at the moment. Hopefully, maybe perhaps that you all have experience, and all this is just a recap on the principles of the technique. If any of you also have ideas or cases, or if you have any things you'd like to share with us, please do. I can see the participants there. I won't call you out by name, but look forward to hearing your comments and or questions as we go along. So please participate this afternoon if you can. It makes it much more interactive, and I'm sure you've got a lot of experience that you can share with us as well. Great talk, Nick. You know, you're a great, great asset to our faculty, and very good techniques, clear slides, and good cases, and very useful. And I'm sure, as you know, this is of great benefit to the patients when it can all be done in a single surgery, and we can get on with rehabilitation and various other things. Excellent.
Thank you.
So Professor Hemant Sharma, who's one of the directors of the Hull Deformity course, with us as always. Looking forward to a few of your cases, and particularly, again, focusing on the technique, because this sort of method is very technique dependent and planning is essential. Thanks, Hemant. Unmute yourself, Hemant.
Yeah, okay. Can you hear me now?
Yep, great.
Sorry, thank you. So, my name is Hemant Sharma. I work at Hull, and we do similar kind of things like my other colleagues, Mr. Jotakis and Mr. Dikivet, who does the similar things. And today I'm going to talk a bit about, we do a bit of revision about what we've already said by Mr. Jotakis, and a bit of, I'll give you some steps in the sense, give you some ideas, hard to be very precise with every step in these talks, but I'll give you some idea that how I do it. And so the idea would be that while I'm talking, I'll give you, try to go through the sequence of steps so that when you do your surgery, it would be helpful to you. And I'm sure you all are experienced, and this is just a revision for you. I will not talk specifically about potential problems, but as we go through, I'll highlight some of the things in which, if done with due diligence, then perhaps the problems won't arise. So this is just a quick revision, because this is one of the common problems which we face all the time. So just a quick revision. So if you see where to place the pins. So if you're nailing the tibia, this is your, so that's your entry point. Now as Mr. Jotakis pointed out, this area is open for you. And again, you can put the pins interior in the crest. And what that will do is that will keep these pins are out of the way. And if you look at this, if you're doing a metaphysis, again, has been pointed out that pins have to be perpendicular to the bone, and then when you make them straight, they come through. And because where it's corrected, it uses rule 2 with a bit of a zigzag. But again, if you put your pins back or the wires back, then you have enough space to put your nail. These pins you can put interior, or as Mr. Jotakis said, you can put very distal, and then you can put slightly short nail. If you're plating it, then again, it's the same thing. You put the pins on the opposite side. So all this area would be available for you to put in your plate. Again, while doing the femur, you have to put the pins posterior, has already been mentioned. So, but if you going to, the proximal pins can be difficult, and because of the muscle mass, it's not always easy to put them posterior. And therefore what you do is you mark your nail, and then anything proximal to the length of the nail would be fine. Then you don't have to go posterior. You can just put your standard pins. Now there are a number of ways, and this is just examples from the monolateral kind of fixator, but this is not the only way. And if you're going to put the plate here, then again, move the distal pins onto the opposite side, and then you have all this area available for you to put on your plates. And this is just an example on the bone. Now, what is available to us? So the number of things available: hexapod assisted, Ilizarov, which means hinge assisted, monolateral, and there's something new which has come out, which is unilateral cortical fixator, and I'll give you some example of that. Most common is hinge, which I use. I rarely use hexapod, it's expensive, and it's only reserved for very complex deformities. we can do most of the work from the Elizarov hinge assisted, which is the common, easily available, and gives us fantastic results. Now, the principles of this is exactly the same each time you use it. You use a ring, the ring has to align, each ring has to align to perpendicular to its respective segment, and or align parallel to its axis. Once you've done that, you can plan the osteotomy, correct it, whichever system you're using, check your alignment, and fix it with a nail or a plate, whichever you're planning to do. And this is an example. Now, if you see, this is a hinge assisted, Elizarov assisted. This is my hinge here, which is locked, the back and the front hinge. I've left a space here to put my plate on. So this is a 2/3 ring, which is turned the other way around. Then what I've done is I put this axis parallel to the distal axis from this ring, and then proximally I have put the axis parallel to the proximal segment. Now this will, as long as you align it, it should correct automatically, and all you have to do is put in your plate or a nail. So let me show you an example of a with Elizarov hinge technique. So what you do is first you mark your joint line, then you mark where your distal end of the plate is going to go, because we need to keep the plate proximal to the Blumenstadt line. Then I marked my osteotomy, where I'm going to do the osteotomy, and I marked my plate size 6 and 8 hole, just in case. I knew 6 was enough, but just in case I need 8 hole, I've left a bit more space. So once you've done that, all you need to look at is the frame. Now in this frame, I've left the space here because I'm going to plate. So all the space is open for me, and I've turned the ring other way around. Hinge is there. And the simplest thing with the hinges that is the right place is put the hinge and just bend your frame, and if it will bend quite nicely without any problems, then the hinges are usually at the right place. Then I put it on the leg, and at this point you can put in your pins. So I marked the osteotomy, and these are the pins, and you will see these are the pins laterally. You can put one lateral, one anterior pin. It really doesn't matter. And these pins are on the medial side, so they are completely out of the way of your plate. These are also these computer trackers are there. And what I use is, along with the normal methods to look at the axis of the leg, I also use a computer navigation. Now there's no separate platform, but we use B-Braun knees. So I use either knee software, a total knee software, or the HTO software, and either one will give me long leg axis. And I'll show you some example later on. Now, once you've done that, all you have to do is do the osteotomy, correct it, and lock your hinge. Once the hinge is locked, you can open it up. Here is a closed wedge osteotomy. So put 2 wires. I'm going to put my, I'll take the bone segment out between the 2 wires. Once I've done that, I corrected it, checked my alignment, and put in a plate, and basically put the screws proximally. And this is basically, you're done and dusted. Now, how do you check the alignment of the limb? Now, there are a number of methods. Some people use diathermy. You can use a long guide wire. You can use long rods connected with the hexagonal columns on the rings, or computer navigation, or combination of any of those techniques. They all do the same thing. And I'll give you an example of a diathermy method. So this is oblique plane and a translation deformity of the femur here. So you put, once you have corrected the deformity, you put your diathermy in the center of the knee to the center of the ankle. And if you see the knee, it should pass wherever you have to, where you planned it, usually the center of the knee. Occasionally you'll find your fixation is slightly flexible, and there is a risk that it might, there's a tendency of rebound. In that case, you just slightly overcorrect, but normally otherwise you don't have to. So the same case here, what I've done is I've corrected it with the fixator assisted nailing, and the axis has come straight. Now, all I've done is measured with the diathermy method. Some people even use a plate occasionally to hold the osteotomy. That is acceptable as a temporary plate while you're using a nail. And there's various methods as long as you can stabilize the segment. And how does it work with the navigation? So this is a 40-year-old lady with a grade 4 osteoarthritis of the knee and some changes on the medial side. But here what the plan was to slightly overcorrect it. So you put this diathermy center of the hip, center of the ankle, and it passes just medial because I wanted to overcorrect it, because I was very worried. It was so much. Normally you correct the lateral compartment to the center. This one I just overcorrected because of the severity. So here, these are the pictures of the computer navigation. Here you see there is prior to surgery, there's a 7 degrees of valgus, and the mechanical axis or the weight-bearing axis is 60% in the lateral compartment. Here, what you do is, so I want to put it here. So when I corrected it, what happens, I had to correct it in a varus rather than the neutral. So there's a slight varus, and the weight-bearing axis is about 30% or the 1/3 on the medial side. There's a picture, you cut the plate, put the plate, it's healed, and this is your axis. So this is overcorrection as we wanted it, and it's inside on the middle compartment. Then some examples of UNYCO assisted. So what is a UNYCO? It is a unicortical pin fixator, and what it does is it needs 4 pins in each segment. So 2 in this and 2 in this, and usually this angle is slightly variable, but usually about 100 degrees. If you put it in, it goes just to the single cortex, and what it does is whole of the medulla here is available for you, so it doesn't breach the medulla. So with the fixator on, you can ream the canal, you can put in a nail, and you don't have to worry as much that with the normal fixators where you have to put your pins. The other big advantage is because there's a torque controller on the system, you can only torque it onto your one cortex. It automatically stops, which means that it can be applied very quickly. And we have timed it in a theater. And if I remember correctly, it's about between 10 to 15 minutes, you can put it the whole fixator very easily. So this is an example of, again, the valgus deformity of the femur. Now here, this is the plan, but the trauma cat doesn't have dome osteotomy, but so the plan was to dome, but this is just to check the axis. So we planned it where to correct, how to correct. And then with the same thing, I mark the leg, I decide where my plate will go, do all the lines. And then before I start, I put in a single pin, and I did pin holes for the dome osteotomy. So once I've done the holes for the dome osteotomy, I don't complete the osteotomy. Then after doing this, take the pin out, and then I put in a fixator. Once I put in a fixator, I go back and complete the osteotomy, because that way I have control over the segments. And this is the theater picture. So once I've done the osteotomy, I've decided, I've corrected it, and then here is the UNYCO on. By looking at it, I should have cleaned the leg. Actually, it's looking very horrible and bloody. My apologies for that. So this is the fixator on the proximal and distal segment. Here I've corrected it, and I'm measuring it with my with the diathermy method. And as you notice, there is also a computer navigation tracker on it. And once I've done that, I see that there's the center of the hip to the center of the ankle, and passes from the center of the knee. This is where I wanted. Then what I do, I put my rod on. So this is it is connected by single rod. It is quite stable. Once I've connected it, I've stabilized it, tightened everything. My osteotomy is stable, and all I have to do is open it and put in the plate. Before you put in the plate, it is always a sense of caution. So what you do is you put one screw in the distal segment and one screw is the proximal segment. So stabilize your osteotomy and then recheck your diathermy, recheck your alignment, because occasionally what happens that your osteotomy can move and your position can change. So before you finally fix the plate, put one screw on each side, recheck the alignment. Once you check the alignment, then complete the plate and put all the screws. So this is the pre-op pictures. This is the final picture. There's a bit of a translation because I've used the osteotomy rule 2, and because as you know, in the dome osteotomy, there's always an element of translation. So this is corrected, and these are the post-op pictures. Now, this is a separate patient, but what I want to emphasize here is I'm trying to do a fixator-assisted deformity correction, and this patient had a total hip replacement. And despite the hip replacement, you can see the unicortical pins are there, and they are not touching the stem. So it is a very good device because it can help you. It makes your life easy. And this is another example, another patient where I put in a fixator with the fixator on, and I don't have to worry about whether I put the fixator on. I just reamed it and put in a nail with the fixator on, and just once it's there, you can take the fixator off and lock it. Occasionally, I do a 2-stage procedure, which I'm going to do. I'm doing more and more these days. So this is a young chap and needed a high T-well osteotomy in late 30s or early 40s. And the plan was to do it with a frame, but he couldn't have a frame for the full length because he couldn't go to work. So we thought we'll do a 2-stage procedure, which I'm doing actually, as I said, more and more these days. So here, when I put in the fixator, I do not put any pins on the medial side because this is where my plate is going to go in stage 2. So what I've done is I've done the frame, and then I put all the pins on the lateral side and left the space open, empty. So once you've corrected it, you're happy that you've reached the desired correction. Then now this other thing what I do is you can put in a 2/3 ring, or what you can do is in orthofix you have 5/8 and a 3/8 ring. So the 3/8 ring which can come off, I always put on the medial side. So my 3/8 ring is always on this side. So what happens with this on here, I have a full space, and all I have to do is then I have to stabilize it on the laterally and take the 3/8 off, and then all I do is I've got a plenty of space to go in and put in my plate. So 4 weeks later, once it's corrected, I went in, took the medial bit out, this bit out, put in a plate, and this is healed, so he could go back to work, and also at the same time had the best of both the techniques. Because one of the problems with the X-Fix related internal fixation is single stages, that if you don't correct it, there is no coming back to that. It is under or over corrected as you have done it. So your checklist for plating, so checklist for fixator internal fixation, they both are the same, but I'm going to run the list for the plating. Prior to surgery, as Nikos pointed out, planning is absolutely crucial. Absolutely crucial. I cannot emphasize it enough. We need to also understand where the final position of the corrected fragments would be. Will there be any translation, and how you're going to tackle the translation, whichever way you want to do, bend the plate or leave the plate prominent, doesn't really matter. Please check that the systems you're using are compatible with each other and they don't come in each other's way. If you're not sure, write the plan and put it on the theater wall. It's always a good learning exercise and it's good for training. During surgery, mark the length of the plate, pre-drill the osteotomy first, then apply the external fixator. Once you've done the fixator, plant the fixator in a way that you have enough space for your plate, complete the osteotomy, correct, check your alignment, then see, do you need to overcorrect? But either way, start putting on the plate just stabilize the segments, recheck your alignment, and then put the final screws in the final plate. So to summarize, please follow the deformity principles. They are absolutely critical, and more for two reasons. One, for me and you to understand that how to do it and what is the final position of the segments, and secondly, to avoid any secondary problems. Pre-planning is absolutely must. You must remember what device you're going to use. Are they compatible? How much you're going to correct? Do you need to release the nerves, or you don't need to? That also should be on your mind. What is the soft tissue like? All that needs to be taken into consideration. And if you can't correct it first time round properly, there is no post-operative remedy. You can't come back and do something later on. Therefore, it's very important that you correct it right first time. Thank you very much.
That's excellent, Hemant. Very good. Again, a tremendous amount of information that we have there. So I think we've got quite a bit of time now to sort of discuss a few things. A couple of questions that have come up and I think are good for discussion. The first question to the panel really is, when you're creating an opening wedge osteotomy, do you ever graft the wedge? And I think what we're looking here is for your ideas about the biomechanics of the size of the wedge, where the wedge is, and your fixation, and also patient factors. So what are those? When would you decide that you may require grafting as opposed to not?
When I do it, it depends on all those factors in the soft tissue, vascularity, and also the age of the patient. In young patient, I tend not to. In elderly, which a lot of them come prior to knee replacement, in those cases, if number one, avoid the opening wedge, because there's a risk of non-union, and I have one or two patients which I ended up with a non-union, so I tend to do a closing wedge or do a dome osteotomy. But if you want to do, then I would graft in the elderly patients, or who have number of comorbidities with compromised vascularity.
Excellent. So, patient factors, sort of underlying medical problems, as you mentioned, smoking, non-steroidals, use of various types of carbonated drinks, as we know, slows bone healing down. And looking at the osteotomy as well, you can also, instead of doing a very large opening wedge, you may change the type of osteotomy you do to increase bone healing, increase the surface area to obviate grafting. And again, also depending on, is this a staged procedure towards a knee replacement as opposed to deformity correction or post-traumatic deformity correction, would you require grafting or not? So I think that's good. All those factors are above and very important as part of your overall planning strategy in doing this technique. You're going to be looking at all those factors, because that helps you decide what method you will use for deformity correction. Excellent. So again, to both of you, if you're using external fixated plating, proximal tibia or distal femur, wherever, what is your rehab program, your weight bearing status? What do you tell patients, and how do you go about that?
So I take this.
Nick, maybe Nick.
Yes. Our approach is generally a partial weight bearing initially. That's a general rule. Usually, on average, you look at approximately 30% with plates for the first 6 weeks. Now, there's no absolute rule, and I think this question somehow relates a little bit to the previous, because we started discussing a little bit about contact. It came from the question on bone grafting, but in reality, as we know, stability relates to not only the implant, but also the bone contact. So if we have a rule 1 and I have excellent contact, I have more than 70% bone contact, the 30% with plating I have referred to could increase. So I may let my patients weight bear more up to full weight bearing within 2 to 3 weeks if I have more than 70% contact in healthy, good quality bone. So I will have to look at all the factors in addition to the plating per se. such as how much contact, bone quality, and obviously purchasing good quality bone versus osteoporotic bone.
Yes, I think that's a very good point. So, given normal patient factors or patient factors you can control, and this comes from AO originally many years ago as well, is that when you talk about stability of a fracture, it's the stability of the reduced fracture. In other words, biomechanically, what bone stability can you achieve? What plate stability can you achieve? A combination of that determines, what sort of weight-bearing status you can have afterwards. But I'm sure you will all agree that one of the reasons we're doing this technique these days is to improve rehabilitation, to speed up rehabilitation. So we want these patients weight-bearing as soon as possible. It's good for bone healing, it's good for biology, perfusion, the muscle function. And we want these patients, particularly also, I think it needs to be mentioned, is joint range of motion. We're operating often around joints, near joints. I think key and the ultimate outcomes of these patients is often determined by the joint range of motion they have, not necessarily by the accuracy of your correction. So certainly both of you have very good limb reconstruction units, and I think your physiotherapy, involvement of physiotherapists, perhaps pre-physiotherapy as well as post-physiotherapy, incorporating these factors is very important, so that the overall plan you have also takes into account, with the following plan I have, with the fixation I have, what can my physiotherapist and the patient do afterwards to achieve that sort of final outcome. So I think both those are very good questions and very important contribution to the overall method.
Absolutely, and Gavin, I'm sorry for interrupting. I think the point you raised is so important because ultimately, the whole idea of the acute correction of the X-fixation system technique is to promote early rehab, less hindrance that you will have with an external fixator, and joint motion, weight bearing are the greatest examples of goals you can achieve with this technique. So, thank you.
Good, and also think, we talk about the overall sort of value of the procedure, and you're looking at the quality of the outcome versus often sometimes the cost of what we're trying to achieve. And people do ask, about, we're using this fancy equipment, we're using double equipment to achieve the same thing. Is there quality of outcome versus cost? And I think there is, and I think there are some studies that are coming out and have come out in this regard. But I think what you said, and also what Heyman has said in terms of the type of fixator assistance you use, can be very simple fixators, reusable fixators. It doesn't have to be anything fancy. It doesn't have to be the latest, fanciest hexapod type fixator. You don't have to use a computer. So wherever you are in the world, whatever technique you're using, you can build your own fixator assisted technique, providing you stick to all the principles that have been mentioned today and all the techniques, which I think are very useful. So I think that's been excellent. Okay, guys, and the participants, any more questions you guys can come up with? Any comments you'd like to make? Anything you'd like to contribute? We'd obviously value that if you'd like to. We still have a few minutes left. I'll ask another question while you're thinking, guys. So panel, if you were saying to somebody starting out with this technique, what would be your sort of ideal case that you might want to say, this is a good case to start out? If you're starting this technique, try this case first. Any ideas? Difficult question, but because it's so advanced. But would you use nail? Which is easier, nailing or plating?
I personally would recommend definitely a simple correction. So in that, again, often if you look at limb reconstruction techniques, or even if extrapolate this to trauma, let's say we start talking about frames towards, I'm bringing frames in the equation because of the speciality, but typically, the more complex injuries may end up with a frame. And when do you start as a limb reconstruction surgeon applying frames? On the beginning of your career, you try not to learn doing this with a more complicated bone loss case. You will try to do maybe a fresh frame with a distal tibial extraarticular fractures. I will do the same with the deformity. I will try to look at a relatively simple deformity, maybe the physical rule 1, and try and practice my pin placement to start avoiding the path of the nail. So certainly not a complex deformity. Uniplanar maybe the physical rule 1, or even if it's a rule 2, not a particularly complex deformity as such. So rule 2, whereby there's no big distance between the osteotomy and the cora, and you don't worry too much about translation, you might get it wrong. So simplicity will be the answer, really, and then you build up your skills.
And the only thing I'll add to that is that apart from that, 2 more things. One, plan it, draw it on a piece of paper, and I mean, I never had trauma CAD until very recently, and I used to pull all my X-rays on a PowerPoint, print it, and then take a tape and scissors, and used to do my osteotomies and stick it with the sticky tape and just put it in theater. This is what I'm going to do. And so something simple. And also, I think just check the using this familiar fixator. Now, I find LRS hard because my experience with LRS less. I'm very comfortable with hinges. Similarly, some people might be better with LRS. So whatever system you are familiar with, use that system to start with, and then go to complex deformities and different options.
I think it's a very important point. Whatever technique, whatever implants you use things that you're familiar with, that you're comfortable with, not just because somebody fancy happened to mention in a talk somewhere, it doesn't mean to say you have to use that. So familiar implants are very important. Perhaps also I might say that, nails and diaphyseal deformities, rule 1 are good. Metaphyseal deformities, plating is a good thing, because just remember with nails, particularly with the more complex deformities, certainly in some of your slides, it showed up you were using polar blocking screws. So with nails, if you're doing deformity correction and nailing, then you want to make sure that the end construct is stable. Nails, intradural, metaphyseal region, not necessarily, and therefore blocking screws would be very appropriate. So that was a little point, some of the cases you brought up. Excellent. So maybe just to counter that, so what would be your nightmare case?
Okay.
What's the case you think, oh dear, this is going to be a challenge?
I worry about cases where there is number of previous surgeries. Is then what you don't know the quality of the bone. So there are a number of factors which come in. If you don't know the quality of the tissue, which means the vascularity can be compromised, and also when you're trying to acutely correct it, would there be a problem? And 2, the risk of non-union increases. So I feel very, and I think also the multiplanar deformities, along with those I find very hard. You have to think a lot, you have to plan a lot and practice a lot, and you worry a lot.
Yeah, I think also for me, I think also if you've got significant soft tissue problems, scarring, burns, radiation therapy, flaps, previous vascular reconstructions, to me, all the above bone things, yeah, I know that, but we can handle that. We know about bones, but that soft tissue element, when you're having to incorporate the planning of what's going to happen to the soft tissues, and any soft tissue reconstruction we have to do halfway through, I think is also key. Excellent.
Also, the patient with the unrealistic expectation, it could be the other particularly difficult patients who, whether personalities or what they've been through. I think this is, I'm more worried about a patient where I cannot engage and have a common plan that makes sense, agreed. I'm more worried about them really, because the complex deformity in the skull tissues, at least, there's a compromise. You can agree to what we can achieve. But if you have patients who have stuck in their mind what they want, which may not be realistic, And I find actually for the more difficult, let's say, other personalities or patients who may not cope as well with treatment as well, I find the X-Fix assisted technique being particularly useful because the job is done, less follow-up, so less issues then to, as long obviously this is done as you know, at best. So.
I think that one slide you had, Nick, of the dog with the external fixator on was excellent, because what you saw there was the dog was obviously going to lick his pins, but we like different pin site care than he may expect, and so he had this hood on his head.
Absolutely.
So there you were managing the patient's problems while doing your reconstruction. Excellent. Good. Okay, any more questions from the participants? Okay, if not, then just to conclude, I think we've had a great day today. And if you can see my slide there, I think it's been good. I hope you guys all enjoyed it and learned something and have some ideas and things that you want to go and do when you get home or at home with your next cases. Can I just remind you that there's the whole deformity course next year, which we're hoping to run pending what happens with COVID.
Can't see your screen, Gavin.
Can't you see the screen? Okay. I'll try again. Let's see if we can go to.
I can see him.
Can you see that now? Is that better?
Oh yes, his screen we cannot see.
Oh, you can see the screen. Okay. So just to remind you guys, those who joined this webinar, perhaps you'd also like to join the next webinar, which again is a very nice subject, a very useful subject, and sometimes there's a lot more to it than you might initially think. Is the management of leg length discrepancy on the 9th of the 1st next year. So we look forward to seeing you all then. In the meantime, thank you all for joining us, and particularly thank you to our two speakers. I think you had great talks today. They were very clear, a lot of information, all the principles were there, and that is very useful to take home and use when you get home. So I think we can perhaps close the webinar. Thank you, Mike.
Gavin, just one last thing I wanted to say, that it would be available very shortly on the YouTube as well, on the Deformity Course channel. So if somebody has missed it or somebody wants to tell their friends, they can watch it as well.
Excellent.
Thank you.
Good. Thank you very much. Goodbye, everybody. Have a good morning, evening, day. Cheers, guys.
Thank you.